Hello everyone, my name is Francesca Palandri and I am a hematologist dedicated to the treatment of MPNs at the University of Bologna in Italy. We know that the Simplify-1 trial is the only head-to-head study of JAK inhibitors, and it compared ruxolitinib, the JAK1, JAK2 inhibitor that has been the standard of care for many years now, and momelotinib, a new JAK1, JAK2 ACVR1 inhibitor that is currently approved for the patients with myelofibrosis, showing splenomegaly symptoms and moderate to severe anemia. In the overall cohort and also in the subgroup of patients with a baseline hemoglobin less than 10, momelotinib was non-inferior to ruxolitinib in achieved spleen volume response 35, which means a reduction by at least 35% in the spleen volume compared to baseline at week 24. In our analysis at ER 2025, we wanted to explore the probability and also the clinical significance of achieving a dual response on spleen and on transfusion independency. We observed that in the patients with baseline anemia, the rates of dual spleen and transfusion independence response at week 24 were higher with momelotinib, 27%, compared to only 7% with ruxolitinib. Notably, dual responses were higher with momelotinib across all the subgroups defined by factors like age, risk score, platelet count, and also baseline spleen volume. When we looked more closely at the spleen and transfusion independence responses in the patient with a platelet count greater than 200, we observed that the rates were higher with momelotinib, 19% compared to 13% with ruxolitinib. So I believe that here we have an important clinical message. While the spleen response rate may be higher with ruxolitinib in the patient with a platelet count greater than 200, this spleen response with ruxolitinib often come at the expense of transfusion need. So whenever we improve the splenomegaly with ruxolitinib, we generally acquire anemia. But what is the impact of transfusion-independent response or of dual response on the outcome of our patient? Because this is what really matters to our patients. And to answer this important clinical question, we performed a Kaplan-Meier overall survival analysis according to the response status at week 24. For the patients who were transfusion independent and or achieved a spleen response at week 24, the survival was longer compared to the patients with no response at all. But most importantly, the survival was comparable whether the patient were transfusion independent alone or also achieved a dual response with a spleen. So my final take-home message are that momelotinib may achieve higher rates of dual spleen and anemia response in patients with baseline anemia. Transfusion independence may be more strongly associated with overall survival in momelotinib-treated patients compared to spleen volume reduction. And I think that so far we are accumulating a growing body of evidence that transfusion independence in patients with anemia should be the great priority over spleen volume reduction if we want to optimize long-term outcomes. Thank you.